and then very low in obstetric patients. So we don't see a lot of HIT in cancer. Do see pseudo HIT, where a syndrome, not paraneoplastic, but something like that. It seems to appear with a thrombocytopenia, sometimes HIT test positive. It doesn't appear to follow the normal rules of HIT, and usually gets better when the cancer is treated, pseudo HIT. But yeah, HIT doesn't appear to, I mean, I know it's a small cohort generally, these patients who are getting low mercury heparin compared to the general cohort, but it seems to be lower in non-surgical patients, even the cancer patients. I worry most in the surgical patients. You might see it in patients who have cancer surgery, and that is a slightly more worrying group, particularly the abdominopelvic cancers, 3-4 weeks. But there again, we tend to see more HIT in high doses, the treatment doses, prophylactic doses, and even the abdominopelvic cancers will only get 4 weeks of prophylactic dose. So yes, monitor the platelet count, but it doesn't seem to be a for clinical problems we thought it would be.
Dr. Battelvies, is there any new data on the anti-cancer, on the potential anti-cancer effect of low molecular weight heparin in this context?
Yeah, that's great. I don't think there is convincing data, and in fact, the ASCO guidelines, I didn't speak to it, but there was one of my slides. In fact, they've pronounced ASCO that if you want to prolong life, don't use heparin to do it. Essentially, is what ASCO say. So, ASCO certainly don't believe the data, even the latest data. There are always, non-significant trends to possibly improve survival, possibly because patient selection in those studies. But again, all these studies are so heterogeneous and so small. It's very difficult to get a convincing signal. So I would say no new data that's convincing, and certainly no guidelines that would support giving heparin for survival.
Dr. Patel, it's apparent from the heated discussion that the lecture was so elegant, so comprehensive, and so interesting to all of us. Thank you again very much, and hope to see you again in Jordan. Thank you very much.
Thank you. Have a successful conference. Thank you.
Good afternoon. يعطيكم العافية جميعا والسلام عليكم. We're going to move to the next session now. Our next speaker is Dr. Amer Zeidan. Dr. Amer Zeidan is well known to us. He's going to talk about ASH update in regards to acute myeloid leukemia and MDS. So Amer is Jordanian, and he's Associate Professor of Medicine and Hematology at Yale University and Medical Director of Hematology Early Therapeutic Research and the Director of CME at the Hematology Division at Yale Cancer Center. Amer completed his Hematology Oncology Fellowship and Clinical Research Fellowship in MDS at Johns Hopkins University, where he earned his Master of Health and Science degree in clinical investigation. Amer specialized mainly in the management of myeloid malignancies, especially in MDS and AML. So Amer has been away from Jordan due to the COVID and coronavirus epidemic for the last 1.5 years. And I guess he arrived to Jordan in a visit, in a small visit or a short visit, probably 48 hours ago. It would be a pleasure for us to have Amer talk again in our conference about MDS and AML. Amer, are you with us? Amer? Amer, are you connected? So while Dr. Amer Zeidan is connecting to us, please let's mute all of our microphones so we can have a clear lecture. And if you have any question or you want any question, please type in the chat. At the end of the presentation, we'll go by names that listed in the chat for the questions. let me ask the organizers, is Amer connecting? Dr. Abdullah. So Amer is here and he is connected. Okay, but he's connected, I think, to a different session, probably a different virtual session. In a few minutes, he will be with us. Amer, you are mute. Amer, you are still mute. So Amer, you are mute. You can just click one time. Okay. Okay, you are not mute. You are not mute. Yes, can you talk?
Yeah, can you hear me?
Yeah, I can hear you, and I guess everybody else is hearing you.
Excellent.
Probably,
sorry for all these technical glitches. So hopefully you can see this now.
These are technical glitches, huh?
Yes.
So I have introduced you to everyone, okay? And I said you are here in a visit to Jordan, right? But unfortunately, though you are in a visit to Jordan, we couldn't have you in person. We had you even in Jordan virtually.
Well, thank you so much. It's always a pleasure إنه كل واحد مع كل الناس في الأردن. Just to make sure you guys are on schedule, should I try to reduce the talk to around 30 minutes, or do you want me to go as original?
Well, actually, I think it's 35 minutes is good, okay? And
Okay, I'll try to
we'll have enough time for discussion.
Perfect. I'll try to skip through some of the slides. So again, thank you so much for inviting me today. This is an update from the ASH Hematology meeting, basically on acute myeloid leukemia and myelodysplastic syndromes. So these are my disclosures. So I'll start with AML and then go to MDS. So for AML, I think one of the major problems have been always improvement of outcomes in older patients. What you can see here are these are the outcomes even in the US, you know, and what you can see to the right lower hand is that the outcomes have been quite poor over the last 40 years. There have been some improvement, but the median overall survival for patients who are older than 65 remain quite poor despite all the improvements we had. And even with induction therapy, when you look at older patients, this is a large database study that we conducted. What you can see is around 25% of patients either die in the hospital during induction or they go to hospice when they are older than 65. Again, highlighting that induction therapy, intensive chemo, is probably not the best way to go after for older patients. The introduction of hypomethylating agents has been a quite important breakthrough for patients with AML. However, what you can see here is the survival in real life analysis of decitabine and azacitidine, the two approved hypomethylating agents. You can see that there is survival is around only a median of 8 to 9 months. And there's actually no difference between azacitidine and decitabine. So I tend to use both of those agents depending on the particular circumstance of the patient. One of the main problems in the US, and I think from discussions with many of my colleagues in Jordan, is that many older patients with AML are not treated. What you can see here in the bars are the percent of patients who are untreated in the blue bar. And even in the US, you can see more than 40% of patients who are older than 65 have not yet been treated. We are hoping that this is going to change as we have many new therapies. This data is as recent from the year 2013. So as this gets updated with the new drugs, we are hoping we are going to see more patients being treated. I think one of the important messages that came from ASH meeting is the increasing use of MRD negativity as a marker for long-term survival and better outcomes. So we are really using this protein in our patients, not only looking at complete response, but also at MRD negative CR, which can be done either by flow or genetic assessment. And MRD negative CR is becoming a recognized criteria. You can see here the evolution of the endpoints in acute myeloid leukemia, and MRD negative CR is becoming more and more recognized as an important endpoint. And we have a randomized study that we just launched here in collaboration with the National Cancer Institute, where we are randomizing patients to receive 7+3 or 7+3 with pembrolizumab, the anti-PD-1 therapy, with the MRD negative CR being the primary endpoint. And I suspect we are going to see more and more of those studies. So why are the outcomes of AML have continued to be poor over the years? I think a big part of this is because of the large heterogeneity within AML. And we tended to treat AML as one disease, but now we realize that there are many different drivers, and each biologic entity, sub-entity of AML should be treated differently. And we go into a situation of, what I call guacamole, where you are basically heading one head of the leukemia, and then you are getting another head pop up, another mutation. So the approach really, I think, should be going after the root or the head, the medusa head, what I call it AML, so that the disease will not relapse. And the new drugs that we are having come due in the pipeline is helping to go in that direction. So the year 2017 started a complete therapeutic revolution in acute myeloid leukemia. You can see in this slide some of the landmark studies that have led to approval of several agents. And the way we treat the leukemia now is very different than before 2017. Of course, the issue of the drug pricing and whether some of those drugs have reached a lot of countries outside Europe and the US remains a challenge. But this is what we generally do in patients with AML, and I'm going to go through some of the updates. So what you can see here are the approved drugs, Rydapt or midostaurin, the FLT3 inhibitor, which was approved in combination with 7+3 for FLT3 positive AML. You can see inacidnib and ivosidenib, the IDH2 and IDH1 inhibitor, which are approved for refractory acute myeloid leukemia for patients who have those mutations. CPX, which is a liposomal formulation of 7+3, approved for patients with AML with MRC. Mylotarg or gemtuzumab ozogamycin, an antibody drug conjugate that has been directed against CD33 and now is used often for core binding factor leukemia. It's part of our standard of care to combine it with 7+3 for patients who have core binding factor leukemia because of impressive improvement in survival outcome of those patients. Most recently, of course, venetoclax has been approved, and we use it in combination with hypomethylating agents in frontline management of AML, in addition to glasdegib smoothened inhibitor and gilteritinib, which is a FLT3 inhibitor used in refractory and relapse AML. Most recent approval in AML in the US was oral azacitidine or CC486, an oral version of azacitidine. However, it's very important to note this was not approved as a replacement for azacitidine. It was only approved as a drug used in maintenance setting after intensive chemotherapy for patients who cannot complete their consolidation and who are not going to bone marrow transplant. So now the treatment of AML is becoming very complicated, as you can see. I joke with my patients that you need a GPS now to kind of navigate you through how you treat patients with AML, because it's no longer 7+3 or azacitidine. Now we have many drugs, and we have to look at the genetic landscape of the patient to decide on the treatment. And venetoclax is really changing how we approach AML in general. You are seeing here the top-line results from the VIALE A and the VIALE C, the two landmark trials that have shown that the combination of venetoclax with low-dose cytarabine, which did not improve survival, but with venetoclax, it did improve survival over azacitidine. And this is why now azacitidine with venetoclax or decitabine with venetoclax is a standard of care in the US for the management of older patients who are unfit for chemotherapy. And now we have many clinical trials that are adding to azacitidine with venetoclax. You can see to the right side of the figure, number of agents that are being combined. There are more than 30 to 40 different agents that are being added to azacitidine and venetoclax, meaning that triplet therapy is the way to go in clinical trial development. And now we have oral replacements of some of those agents. As I mentioned, there is an oral version of azacitidine. There is an oral version of decitabine now approved, but for MDS. So now we potentially could be looking at total oral therapy, 2 oral agents, venetoclax with an oral HMA, or even triplet therapy, which will be really changing the landscape of how we view the disease. And this is another example of a study we are conducting where we are using the azacitidine and venetoclax as a backbone to add immune checkpoint inhibitor. Immune checkpoint inhibition is a major area of my clinical research. So we have a number of studies that look at adding anti-PD-1 or PD-L1 therapy to those patients. So going through some of the important abstracts from this ASH meeting. So this abstract, basically from the MD Anderson group, looked at the addition of venetoclax to cladribine and low-dose RC to aza-ven. So this regimen of cladribine, RC, and venetoclax is a regimen they developed, and it actually had some good activity. But then with the approval of azacitidine and venetoclax as the standard of care, they developed this protocol where they alternate between the azacitidine venetoclax with the cladribine RC venetoclax, as you can see here. And the outcomes were actually quite good with this regimen. So the complete response rate, as you can see in this table, was 78%, and CR, CRI, total 93%. So almost all patients respond to this regimen. And again, changing how really we think of older patient AML, in which traditionally azacitidine or decitabine alone, the response rate was only around 15%. Aza-ven is taking that to around 60% between CR and CRI. And some of those new regimens are looking at numbers in the range of 80 to 90%. Of course, this is a single arm study, single institution. So this has to be conducted on a larger scale to see if this could really change how AML looks like. Another important study, and we are in an era in which venetoclax is really being added to all different drugs. So in this here, venetoclax was added to FLAG-IDA. As you know, FLAG-IDA is a traditional chemotherapy that's used for salvage in AML. And again, single arm study from the MD Anderson group, promising outcome, high CR rate, and promising survival. But we need randomized data, although again, I think the data is quite good. Relapse refractory AML, of course, remain as a very major challenge in AML. And what you can see here to the top left was a clinical trial looking at this cytarabine derivative, elacytarabine, compared to 7 arms of chemotherapy, what you can see on the right upper hand, FLAG-IDA, HiDAC, LoDAC, all of those MEC. And what you can see is the median survival with all of these was around 3 to 4 months. Again, telling you how difficult this disease is. So the introduction of targeted therapies, as you can see in the bottom of the screen, inacidnib, for example, for IDH2 mutated patients, CR rate of around 40% and median survival of 9 months, gilteritinib. Those are monotherapies. And of course, we are using these for patients who have those mutations as a standard of care and building up on those backbones to expand on the benefits we can achieve for patients. Venetoclax also has been used in refractory relapsed AML. As monotherapy, it doesn't work particularly well, but in combination with LoDAC or hypomethylating agents, it seems to have activity. This is a systematic review and meta-analysis we've done of the multiple studies that looked at those combinations. And what you can see here is the activity was quite high. with overall response rate of around 40%. So I actually use azacitidine-based combinations in many of my patients who have refractory or relapsed AML after failure of intensive chemotherapy. So now, as I mentioned, we are in an era in which we are combining those agents, the IDH inhibitors, with azacitidine. And this is a clinical trial that we participated in that looked at use of azacitidine with inacidnib in the frontline setting compared to azacitidine alone. And while the response rate was higher with the combination and there was an improvement in event-free survival, the overall survival did not improve. And some of that could be related to the fact that inacidnib is being used as salvage therapy after progression for those patients. Now, inacidnib is also being studied as single agent in the frontline setting. So an oral pill to give for patients who are older and who do not want azacitidine venetoclax, or who do not want to come to the hospital. And I actually have several patients. I've used this as off-label therapy. I had patients who were very old in their 80s and they did not want to come 7 days for the azacitidine, and they happened to have an IDH mutation. So I've given them inacidnib or ivosidenib. This is for the inacidnib off-label, but for ivosidenib is already approved for older unfit patients with AML. In this study, they are trying to understand how to sequence inacidnib with azacitidine. And what they use is inacidnib frontline, and then they added azacitidine to that. And they found activity of around 50% with the inacidnib monotherapy. And when you added azacitidine to those patients who did not respond initially, some of them responded. So this is another way you can use this combination. So you can use azacitidine alone, you can use azacitidine with inacidnib, or you can start with inacidnib and add azacitidine. Another promising combination for the IDH1 inhibitor is patients who have patients who have IDH1 mutations who are not fit for intensive chemo. This is a study we participated in and just got published in JCO, I think a couple of months ago, where ivosidenib and azacitidine were used as a combination for those patients who are older and unfit for AML. And as you can see, again, very high CR rate, around 50%, overall response rate 78%. And you can see the swimmer's plot here. Some of those responses were durable. So the question has become basically for patients who have IDH1 or IDH2 mutation, what would you give them as a frontline therapy? Would you give them ivosidenib, inacidnib alone? Would you give them ivosidenib or inacidnib with azacitidine? Or would you give them venetoclax or azacitidine? Because venetoclax is approved across the spectrum, right? Venetoclax is approved for all older unfit AML, regardless of whether they have mutations or IDH mutations or not. And what you can see here is a sub-analysis of the VIALE-A study, in which they looked at venetoclax and azacitidine for patients who have the IDH mutations. And what they found that the CR rate was around 80% with an overall survival of 50% at 2 years. So half of the patients were alive 2 years after starting the therapy, which again, I think is quite impressive and clearly better than azacitidine monotherapy. So I think based on this data, I still use azacitidine venetoclax as frontline therapy for patients with IDH mutations, and then use inacidnib or ivosidenib for refractory patients or after relapse. Another important development from ASH has been better understanding of the oral azacitidine. This is the COSAR study, the landmark study that was just published a month ago in the New England Journal of Medicine, basically showing oral azacitidine being used as maintenance for 14 days every cycle for patients who have received intensive chemo and were not able to continue intensive chemo for different reasons and did not go to transplant. So this is not after transplant, this is after just intensive chemo, and for older patients who were